Welcome back to this multi-part series outlining our approach to the resection of polyps less than 2 centimeters. Again, my name is Dr. Jeff Moscow and I am a gastroenterologist and advanced endoscopist here at the Center for Therapeutic Endoscopy at St. Michael's Hospital. In part 1 of this series, we reviewed some data showing the very high yield of FIT-positive colonoscopies, an initial approach to all polyps, as well as some of the equipment required for effective and efficient polypectomy, including colonoscopes, snares, and the electrosurgical unit. Meticulous inspection of polyps is a necessity in order to decide on the most appropriate next steps in management. This includes evaluating the risk of submucosal invasive cancer, evidence of submucosal scarring, and endoscopic access. Together, this allows us to decide on the suitability for endoscopic resections. All endoscopists should be able to identify the tubular adenomas on the left side of the screen and the cis-ulcerated polyps on the right. The Paris classification should be used for morphologic classification. This allows endoscopists to communicate with one another in a common language while also allowing for risk stratifying polyps. The Paris classification consists of protruding lesions, 1P if pedunculated, 1SP if subpedunculated, and 1S if sessile, defined as elevated greater than 2.5 millimeters above the mucosa. There are flat elevated lesions, Paris 2A. There are flat lesions, 2B if true flat mucosal change, 2C if there is a mucosal depression, and 3 if excavated, implying invasive disease. In reality, lesions are often mixed and should be classified as such. The Paris classification should be used in combination with surface topography, granular or non-granular. Simply put, granular lesions are bumpy while non-granular polyps are smooth. Together, the Paris classification and surface topography are helpful in stratifying the risk of submucosal invasion. This graph is courtesy of Michael Burke from the ACE cohort, indicating the risk of submucosal invasion. Contrary to popular belief, right-sided Paris 2A lesions have an extremely low risk of submucosal invasion, versus distal 1S, 2A, or mixed non-granular lesions have a significantly higher rate of submucosal invasive cancer. Once the gross characteristics of the polyps have been identified, paying special attention to dominant nodules, those that are greater than 10 millimeters, we turn our attention to focal interrogation. We use high-definition white light and an available digital chromoendoscopy technique, narrowband imaging with Olympus scopes, BLI with Fujiscape scopes, and/or iScan with Pentax scopes. This evaluation should include assessment of both the Kudo classification of the surface pit pattern as seen here and the vascular patterns according to the MBI International Colorectal Endoscopic or NICE criteria. Tubular adenomas typically have large or elongated pits, Kudo type 3, and an organized brown capillary network surrounding the pits, Sano type 2/NICE type 2. Villus adenomas have more complex branching gyrus-like patterns, Kudo type 4. Submucosal invasive cancer is suspected when irregularly mixed types or non-structural or absent pits are present, Kudo type 5, or when irregular complex branching capillaries or avascular areas are seen, Sano type 3/NICE type 3. As mentioned, it is important to be able to recognize lesions that are already invasive cancers. These are not lesions that should have a resection attempted, but should be referred on for multidisciplinary management. Cancers often have specific appearances, including abnormal and/or obliterated pit and vascular patterns, central depressions, and puckering of the surrounding folds. This lesion was referred to me for endoscopic mucosal resection with outside biopsy showing only tubulovillus adenoma. On my inspection, however, there is clear ulceration, depression, and tethering to the colon wall and alteration of pit pattern in keeping with an invasive lesion. As such, no EMR was attempted. The non-lifting sign is often used to assess if a lesion is invasive. However, this sign does not perform as well as people think with very low sensitivity. Beware of lesions that may not be lifting due to submucosal fibrosis and not true submucosal invasion. The final step in polyp inspection involves polyp measurement. While this has next to no significance in determining a polyp's risk of cancer and whether or not it can be removed endoscopically, there is significant variability in practice. Here, Tate et al. Uses the snare catheter in an insufflated colon to measure polyp size. Knowing that the tip of the catheter is approximately 2 millimeters in diameter allows us to estimate that this polyp is around 2 millimeters. Using the same technique here, the catheter is aligned with this slightly larger polyp and estimated to be 3 to 4 millimeters in size. This becomes slightly more difficult with increasing polyp size, but we can still estimate this polyp to be around 3 times the size of the catheter and therefore around 6 millimeters in size. One other technique that I demonstrate here is the use of an open snare. This requires our knowing the exact characteristics of our snare choice as discussed in part 1. Here, a 10 millimeter diameter snare is opened and placed beside the polyp of interest to allow for a more accurate assessment of the polyp size. Thanks again for your attention. Stay tuned for part 3, where we will discuss further pre-polypectomy preparation and approach to polypectomy based on polyp size.